Good morning to one and all. Welcome Dr. Karunagaran, External Examiner for this YOC, our Director Dr. Mohan, Dr. Anjana will be joining us now, and my dear colleagues and friends. It's a great privilege to welcome you all to the YOC of my student, Ms. Lakshmi, and she will be defending her thesis entitled Secular Trends and Prevalence of Diabetes, Prediabetes, and its association with lifestyle factors in rural South Indian population. So we are honored to have with us our external examiner, Dr. Karunagaran. Just a brief introduction. He is a retired professor from the Bhupat and Jyoti Mehta School of Biosciences, Department of Biotechnology at IIT Madras, Chennai. His main area of research includes mechanisms of apoptosis activated by anti-cancer agents, signaling by growth factor, NF-kappa B signaling, and role of mRNAs in cancer. He has made significant contributions in the field of signal transduction mediated by epidermal growth factor receptors and their ligands implicated in the development of human cancer. He has mentored over 6 MS students, 20 Ph.D. scholars, and several postdoctoral researchers while serving as a Ph.D. examiner for leading universities, and this expertise that enriches his valuation immensely. For his extraordinary research, he was conferred with the C.R. Krishnamurti Lecture Award by the Society of Biological Chemists and the Kinariwala Research Award from the Gujarat Cancer Institute, Ahmedabad. He has served as principal investigators in several projects funded by DBT and DST and has over 100 publications in peer-reviewed journals. I request Dr. Karunagaran to conduct this panel.
Very good morning to all of you. It's a pleasure to be back in your midst. So, yeah, please, Lakshmi, go ahead and make a presentation. How much time you are taking?
45 minutes, sir.
45 minutes.
Okay, go ahead.
Good morning to everyone present here. I am Lakshmi N. I will be presenting my research work titled Secular Trends and Prevalence of Diabetes, Prediabetes, and its association with lifestyle factors in a rural South Indian population. This is the work as done part of the thesis for the degree of Doctor of Philosophy, University of Madras, Chennai. Was carried out under the able guidance of Dr. R. Guha Pradeepa, Executive Scientific Officer and Head, Department of Research Operations and Diabetes Complications, Madras Diabetes Research Foundation, Chennai. I would like to welcome our external examiner, Dr. D. Karunagaran, retired professor, Bhupat Jyoti Mehta School of Biosciences, Department of Biotechnology, IIT Madras, Chennai. Over the 45 minutes, I would like to walk you through my introduction, methodology, key findings, and future implications of my research work. Moving on to the introduction, diabetes is a chronic metabolic disorder characterized by elevated blood glucose concentrations, and it is a major growing public health concern all over the world. The recent IDF estimates showed that around 589 million and 635 million of world's population are living with diabetes and prediabetes. Shifting from the global picture to India, the country is now recognized as one of the major epicenters of diabetes epidemic, holding the second highest number of people living with diabetes, ranking just behind China. Nearly half of all the people are living with undiagnosed diabetes in just 3 countries, including China, India, and Indonesia. So the timeline shown here shows that there is a twofold increase in the diabetes prevalence in India over the 2 decades. And this is the most recent update from the ICMR INDIAB study. It shows the national estimates of 101 million individuals living with diabetes currently in India. Urban area, you can see larger number of prevalence, and while rural area is also catching up contributing to the overall national burden. In contrast with diabetes number, pre-diabetes, again there is an increase in the prevalence of pre-diabetes in urban and rural areas. So it says that, okay. So it says that diabetes is a nationwide problem and it is not only confined to urban areas anymore. So having said the prevalence and huge diabetes burden in India, we have to understand the risk factors for diabetes. Urbanization, diet and physical activity, stress, environmental factors, heat stress, pollution, genetic factors, socio-economic factors, all these are contributing factors for diabetes. Welcome, ma'am. So, having outlined the burden of diabetes in India and understanding the risk factors, why is it very important to concentrate on rural India now? Almost 65% of the population lives in rural areas of India, and there are limited rural data documenting on trends in diabetes and lifestyle patterns. Almost 50% of the population are living with undiagnosed diabetes. That could be due to inadequate understanding of operational challenges in screening and follow-up. And even among those diagnosed, the glycemic control is often difficult. This leading to the gap of lack of evidence on beliefs and behaviors influencing the diabetes control. So, identifying these gaps formed the rationale for my thesis work with the aim to generate comprehensive evidence in integrating epidemiological trends and qualitative insights, and to examine the structural, behavioral, lifestyle and contextual determinants influencing delayed diagnosis and inadequate glycemic control in rural population. These aim guided the four objectives. Objective 1, to identify the secular trends in the prevalence of diabetes and pre-diabetes in a rural South Indian population of Tamil Nadu state, to assess and present the changes in the dietary factors contributing to the burden of diabetes over the 11-year period, to assess and present the changes in the physical activity pattern contributing to the burden of diabetes over the 11-year period, to identify the screening challenges and to document the perceptions about the diabetes prevention and control through focus group discussion among the rural population. This picture shows the entire methodological framework of my research work. It is a mixed methods approach where study 1, 2 and 3 shows a sequential studies which gives us a quantitative numbers, and qualitative studies gives us the reason for those problems. Moving on to the study 1. Study 1, we have compared the Chunampet Rural Diabetes Prevention Project CRDPP, which was conducted earlier in the year 2008 to 2010 with telemedicine project for screening diabetes and its complication in rural Tamil Nadu trend, which was conducted in the year 2018 to 2021. So this study dealt with the epidemiological aspects of type 2 diabetes and pre-diabetes from these two cross-sectional studies. So the objectives of CRDPP include to provide mass screening and diabetes healthcare, to promote prevention of diabetes in rural India through a combination of telemedicine and personalized care. And the objectives of trend include to screen for diabetes, pre-diabetes, hypertension and obesity, to screen for micro and macrovascular complications in individuals with diabetes, to assess the levels of diabetes control among individuals with self-reported diabetes. For this thesis, I have utilized the first objective. To make a robust comparison, I have collated the similarities between the two studies. So the methodology between the two studies in terms of study design, methods and data collection tool were similar, except the blood glucose measurement. In CRDPP, fasting capillary blood glucose test was used to assess the glycemic status, and in TREND, venous oral glucose tolerance test was used. Diabetes is defined as according to the WHO 2006 criteria in both these studies. Prior physician diagnosis were categorized into self-reported diabetes, and individuals whose fasting plasma glucose greater than equal to 126 mg per dl or 2-hour post glucose greater than equal to 200 mg per dl were considered as newly diagnosed diabetes. And individuals with fasting CBG or fasting plasma glucose greater than equal to 110 mg per dl and less than 126 mg per dl were categorized into impaired fasting glucose, and individuals with 2-hour post glucose load greater than equal to 140 mg per dl and less than 200 mg per dl were categorized into impaired glucose tolerance. So here in the CRDPP survey, around 27,104 individuals were included with the across 42 villages of Cheyur Taluk, and around 86.5% of the individuals underwent the fasting CBG test, and upon the glucose assessment they were categorized into normal, which was 78.8%, pre-diabetes, which was 16.3%, and diabetes, which was 4.9%. And to the right, TREND study, around 18,162 individuals who were greater than 18 years of age across 30 villages of Cheyur Taluk, Chunampet village was included. There was a screening coverage of around 83%, and around 94% of individuals underwent oral glucose tolerance test. And upon the glucose estimation, the individuals were categorized into normal, which was 76.5%, pre-diabetes, which was 9%, and diabetes, which was 14.5%. For statistical analysis, descriptive statistics were used to summarize categorical and continuous variables. Group comparisons were tested using chi-square and independent t-tests. Secular trends were assessed using absolute change in percentage points and relative change. Poisson regression were used to estimate prevalence ratios. So moving on to the results. So this table compares the clinical and biochemical characteristics of the CRDPP and TREND population. When compared with the CRDPP, the TREND population were slightly older, with their weight increased a lot, BMI increased, waist circumference of male has significantly increased, and female. There is a slight increase in the blood pressure. Their average income, household income was improved, and formal education status have improved, and agricultural occupation has declined significantly. Smoking declined, whereas alcohol consumption has increased significantly. So here, the overall prevalence of diabetes over the 11 years, if we could see the numbers from 5.3 to 13.7, so there is a increase in the diabetes around 158.5% in this rural population. And when it comes to the gender, around in male, the increase was observed around 5.86% to 16.6%, which was around 196.4% increase over this 11-year period. Among females, the increase was observed to be 131.2%. In contrast with diabetes number, we could see a decline in the pre-diabetes number from 16.7% to 8.4%, which is kind of like a decline by half of the pre-diabetes number. And even in the male, the numbers were dropped to 43.8%, and in the female, the numbers dropped by 54.8%. It shows that the increase in the prevalence of diabetes and decrease in the prevalence of pre-diabetes shows that the rural population has undergone a rapid epidemiological transition here. So here the conversion of pre-diabetes to diabetes window period has shrunken. So it needs to be, urgent intervention is needed in this population. So to understand the factors predicting diabetes in this population, so in the trend population had nearly double the risk for diabetes independent of their age and lifestyle factors. And even age, male sex, BMI, formal schooling, non-agricultural occupation, family history of diabetes were significant predictor for diabetes in this population. So, the summary of key findings. Now, the rural India is just transformed from the emerging phase, expanding phase, plateau phase, and now it entered into the conversion phase, where we could see the increase in the diabetes and decrease in the pre-diabetes, leading to the decreasing pre-diabetes pool is shrinking. Men show a faster conversion rate to diabetes, but the narrowing gap suggests that rural women are increasingly vulnerable, signaling that the epidemic is no longer sex specific. And the possible risk factors was there was an improvement in the formal education and decline in the agricultural occupation, and age, male sex, anthropometric predictors such as increase in the BMI, and clinical predictors such as slight increase in the systolic blood pressure and family history of diabetes were the significant contributors in this rural population. So thus, rural South India is transitioning to a high diabetes burden with faster conversion to diabetes and a marked twofold risk over the decade. The epidemic is accelerating, prevention windows are shrinking, and hence the urgent intervention is needed. Moving on to the study 2 of studying the nutrition patterns over the 11-year period. So to study the nutrition patterns, we have used the Chennai Urban Rural Epidemiological Study, CURES, which was conducted in the year 2008 to 2010, compared with the trend study, which was conducted in the year 2018 to 21. The objectives of the CURE study include to compare the prevalence of insulin resistance syndrome in an urban and rural South Indian population, to assess the complications of diabetes, particularly retinopathy disorders like glaucoma and cataract in individuals in type 2 diabetes. So this thesis specifically utilized baseline characteristics and dietary information from the rural component of CURES to analyze changes in the dietary patterns compared with the trend population. So to ensure the robust comparison, I have collated the methodology of both the CURES and the trend study. So in terms of study area and the study design were all similar. In the sampling technique, every third individuals were invited to participate in the dietary survey in the CURE study, and all the individuals were invited to participate in the trend study for the dietary survey. Here in the cure study, we have used MDRF food frequency questionnaire with 106 items, and in the trend study, it was used MDRF food frequency questionnaire with 180 items. So the MDRF FFQ was used to assess the participants' food or beverage intake over a 1-year period. After the data collected, the daily nutrient intake was computed using the in-house Epineo nutrient database, which is based on Nutritive Value of Indian Foods ICMR, US Department of Agriculture USDA, and other published sources. Here, after excluding the implausible energy outliers and self-reported diabetes number, the data we used for this comparison from the cures was around 6,907 individuals, and in trend around 12,441 individuals. For statistical analysis, normality of continuous variable was assessed using the Kolmogorov-Smirnov test. For comparison, chi-square and independent tests were used. One-way ANOVA for comparing the 3 groups of NGT, prediabetes and diabetes. And multiple logistic regression was used to identify the predictors of dysglycemia in this population, adjusted for age, sex, waist circumference, BMI, systolic and diastolic blood pressure, smoking, alcohol, physical activity, family history of diabetes, total energy intake, total fiber intake, and macronutrients were mutually adjusted in the model. Moving on to the results. So this table shows the general and clinical characteristics of the cures and the trend study population. Here, the gender distribution are comparable with slightly older age in the trend population, and again here the weight has significantly increased with BMI increased, waist circumference in male and female has also increased, smoking slightly declined with increase in the alcohol consumption. So the nutrient consumption pattern of cures and trend study population revealed that there is a decline in the carbohydrate intake over the 11-year from the 77% to 62.1%, and increase in the protein intake of around 2.8 percentage point from 9.6 to 12.4, and again increase in the fat intake as well from 13.9% to 23%. And also we can observe an increase in the dietary fiber intake from 15.8% to 31%. So it shows a rural population is undergoing a nutrition transition phase where we could see a good change and as well as a bad change in this population. So the food group consumption between the cures and trend population, there is a significant decrease in the millets intake, and there is an improvement in the fruits and vegetables intake, and there is also increase in the roots and tubers intake. Meats and meat product also increased, fats and oil increased, and there is a 4-fold increase in the added sugar. So this is the comparison of nutrient consumption pattern across the 3 groups with normal, pre-diabetes and diabetes. So in the cures population, at least we could see a slight difference in the dietary patterns in the compared with the normal. There is a little bit of changes in the dietary pattern among diabetes, but whereas in the trend, it is the same pattern of decrease. So whereas in the trend, there is a same pattern observed of decrease in the carbohydrate among all the 3 groups, which is very similar, and the protein intake is also very similar, and along with fat intake is also very similar. But there is a improvement in the fiber intake. So the factors associated with this in this group for the risk for dysglycemia adding with the pre-diabetes and newly diagnosed diabetes, we could see that the energy percentage consumed from 62% of carbohydrate to 66%, the individuals had 1.2 times risk for dysglycemia in this population. Regarding the protein intake, a slight increase also made a very protective effect. And regarding the protein intake, they're observed as 1.1 to 1.3 times risk for dysglycemia in this population. So moving on to the summary of the study 2 key findings. Over the 11-year, there is a change in the intake of refined carbohydrate and slight improvement in the protein, and there is an increase in the fat and slight improvement in the dietary fibers. So the drivers could be greater food availability, economic changes, evolving food preferences, and poor awareness of balanced diet. And consumption of carbohydrate from 62 to 60% of energy also increase the odds of 1.2 times in this population, and consumption of 23 to 27% of fat increase the risk for dysglycemia around 1.1 to 1.3 times in this population. So, having understood about the prevalence and nutrition patterns, we now moving on to the physical activity pattern. So, to compare the physical activity patterns changes in the over this 11-year period, the CRDPP and the trend study were used. So, any bodily movement produced by skeletal muscles that requires energy expenditure. Activities include occupational activity, household chores, transport related movement, and leisure time physical activity. So, in the CRDPP, the International Physical Activity Questionnaire included 18,697 individuals. It was assessed under 6 different domains, including job-related physical activity, transport-related, domestic, recreation, leisure time physical activity, intensities of work, and time spent in sitting. In the trend study, the MDRF physical activity questionnaire was used, including 14,117 individuals under 4 different domains: work, general activity, transport, and recreation. So, the total minutes spent per week on different domains of physical activity were calculated through the metabolic equivalence in the CRDPP study, and based on the metabolic equivalent minutes, the individuals were categorized into inactive, active, and highly active. So, in the MDRF physical activity questionnaire, frequency, intensity, type, and time, using the FIT principles, the physical activities were recorded based on the individual's response to each domain. The total activities spent were calculated using the physical activity level PAL value. So, based on the PAL, the individuals were categorized into inactive, active, and highly active. So, regarding the statistical analysis, one-way ANOVA was used to compare between 3 groups. For the risk association, multiple logistic regression analysis was used to adjusting for relevant confounders. Moving on to the study results. So, the changes in the physical activity patterns over the 11-year period. Inactivity increased by 21.2% in this rural population, whereas active and highly active decreased by 9.2% and 25.8%. So, if we look at the sex-wise difference in the physical inactivity patterns, The inactivity increased among both the sexes, but the increase, if we could notice that it is very much sharper among males, that is around 59.4% relative increase, and among females it is 7.8% increase. But if we could notice in the CRDPP, the female has already, the inactive percentage is already 50%, and again it's just added here. So now we're going to see the association of diabetes in this population. So moving on to the age wise, here if we notice that the individuals from 18 to 39 years of age, the inactivity pattern increased 300 times in this population, and followed by those aged 40 to 59 years age and greater than equal to 60 years. And this is the inactivity level stratified by glycemic status in this population. So people with pre-diabetes and diabetes were more likely to be inactive compared to the normal individuals. So if we observe the association between physical inactivity and diabetes in this population, inactive individuals had 1.4 times higher risk for diabetes, and inactive women had 1.8 times higher risk in this population. So physical inactivity is the key independent predictor of diabetes in this rural population, especially among women. So summary of key findings. Physical inactivity increased by 21%, indicating a major behavioral shift toward a more sedentary lifestyle in this rural population. High inactivity levels were evident among younger adults, suggesting that sedentary behavior is emerging much earlier in life. Inactive women have nearly double the risk for diabetes compared to men. And overall, the inactivity increased 40% risk for diabetes in this population. So by now we have seen the quantitative studies, including study on diabetes prevalence and the changes in the nutrient patterns and changes in the physical activity patterns. Now we move on to the qualitative component, where it's going to address the screening challenges and the lived experiences from the type 2 diabetes individuals. So, qualitative research, it is an approach used to explore and understand the people's experiences, perceptions, behaviors. It focuses on depth of problem rather than numbers. Why we need to do a qualitative study here? We already know that nearly half of the country's population in India remain undiagnosed, and even among those diagnosed, very few were achieving all the ABC targets. Hence, there is a gap in the screening and the effective treatment. So, based on the rationale, the study 4 were formed to identify the real life challenges in the screening for diabetes and its complications in rural setting, and to comprehend the perceptions about diabetes prevention and control through focus group discussion among the rural population. So the objectives of study 4A to describe the challenges encountered and the lessons learnt in the recruitment of rural residents for a diabetes screening program, which was conducted in the trend study. A semi-structured in-depth interview guide was used to explore the challenges in the screening and the lessons learned. The study sample were field investigators, field technicians, telemedicine technicians, and site coordinator. So these study staff were recruited from the nearby local village who have qualified with a basic undergraduate degree and also reflects the socio-cultural background of the same rural community. So the in-depth interviews were carried out to capture the reflections on challenges and strategies used during the diabetes screening in the trend study. The IDs were conducted in the local language by a trained primary researcher along with the note taker in a private room. Each IDA were lasted for 35 to 40 minutes. A digital recorder was used to capture the accurate information for transcription. A returned informed consent obtained from all the participants before recording, and thematic saturation was achieved after 10 interviews. It means no new insights were emerging, so we stopped conducting interviews up to 10. So the recordings were transcribed verbatim, ensuring that the original language remained unchanged. The transcripts were reviewed, subcoded and coded using the inductive and deductive approach, identifying the prominent themes and new themes, and thematic analysis was performed using the NVivo software. So these were the challenges and the solutions, the themes obtained from the study 4A. I'll explain one by one. So regarding lack of awareness, in many rural programs, it was reported that lack of awareness could be one of the problem for underdiagnosed diabetes. So to address that, we have formulated a pamphlets in the trend population explaining about the diabetes and its complications, and the pamphlets were distributed before the screening program, and we also informed a prior information about the screening time and date, which enhanced the screening participation of this rural population in the trend study. And often transportation issues were often documented for this underdiagnosed diabetes in the rural areas. So doorstep telemedicine services were followed to increase the screening. So regarding stigma, people often fear of being diagnosed with diabetes in case if they get tested. So we have created awareness, providing a supportive screening and at a convenient location so that to improve the recruitment rate. And many of the study staff informed that the less screening rate was reported due to distrust of healthcare providers among the rural residents. Hence, we build a good rapport with the individuals, build a trust, and then we connected with the village leaders and we displayed some study awareness materials to inform the residents about the screening dates and locations. And many cultural beliefs and practices could also hinder the screening rate. So we have conducted community awareness talks addressing the gaps in knowledge, stigma and cultural beliefs. The study staff themselves reflects from the rural community. They often felt they had few language barriers to talk with the rural people about the health related activities. So the capacity building and team bonding activities often conducted to strengthen a rapport among the field staff that motivated them to go and address even the non-respondents. Thus we have achieved around 86.5% response rate in this trend study. Summary of the findings. So, rural diabetes screening was limited by low awareness, misconceptions, cultural beliefs, stigma, competing priorities, and distrust of healthcare providers. Improved rural health infrastructure and free doorstep screening reduced financial, geographic, and social barriers to diabetes screening. Involving trusted community leaders increased the credibility, reduced resistance and improved community participation in screening. Use of posters, awareness talks and community mobilization enhanced acceptance of screening in this population. And finally, a culturally sensitive health education is crucial to address poor awareness in this study population. Moving on to the study 4B to describe the perceptions and practices about the prevention and management of type 2 diabetes among adults in rural Tamil Nadu through focus group discussions. Here, men and women greater than 18 years living with diabetes for more than 1 year and those on treatment for at least 6 months from the trend study were included. So, we have used the focus group discussion guide to explore the participants' views and practices related to diabetes knowledge and diagnosis, use of healthcare facilities, follow-up regularity and medication adherence, family and social support, healthy versus unhealthy food availability, and self-monitoring practices and diabetes prevention. The FGDs were conducted in a convenient village locations, obtaining a prior verbal permission from the village head. Locations were chosen to be easily accessible and comfortable. The data collection team included 2 moderators and 2 note takers. Each FGD lasted approximately 45 minutes. The participants arrived 10 to 15 minutes earlier and the purpose of the study was explained. A written informed consent also obtained. A digital recorder was placed at the center to capture the focus group discussions. A total of 16 FGDs were conducted. Audio recordings were transcribed verbatim. Inductive and deductive coding approach was used. The data coded using NVivo software then exported to Excel for theme organization. So a theme was considered relevant if greater than or equal to 2 participants mentioned the same belief frequently and consistently. So these were the emerged themes and sub-themes. We'll go one by one. So regarding the diabetes knowledge and perceptions, nearly half of the participants viewed diabetes as a dangerous disease. Many believed diabetes was caused by a body weakness or eating more sweets, and some participants experienced shock, denial or sadness after being diagnosed with diabetes, and diagnosis often occurred accidentally. So the example of key codes given here, one of the participants said, I went for fever and was shocked when the doctor said I have diabetes. Regarding the availability and usage of healthcare facilities, so though both the private and government hospitals were nearby, most preferred private health centers, public health centers due to low cost. Private care were chosen by some, but better facilities and special tests were offered only in the private care. So concerns with the government facilities were long waits, unclean environment, poor communication and low dose or side effects of those given tablets. Regarding the regularity of the follow-up, about half of participants attended diabetes follow-up regularly every 3 months, but others were irregular, visiting only once in 2 years, assuming they were normal or due to lack of time. And regarding medication adherence, about half took their diabetes medicines regularly, and the reasons for non-compliance were believed that normal blood test means no need for tablets. Fear that long-term medicines cause kidney damage. Some preferred traditional remedies over the prescribed medications, and some said due to farm work and other daily responsibilities, they could not able to follow the medicine regimen. And regarding the family and social support, many participants received a good family support. They got help with diet, medicine and hospital visit. Only 1/4 reported that they had no family support due to misunderstanding or family disputes or living alone or some financial and family problems. Regarding the availability of healthy and unhealthy foods. So the portion control of rice was found to be very difficult. They needed more rice due to agricultural labor activities. And chapati was disliked by them, saying it is very hard to digest, and some tried millets, but long term it didn't work because of higher cost. And regarding self-monitoring, most participants did not practice self-monitoring of diabetes, and they felt testing was unnecessary unless symptoms were present. And some participants self-adjusted their medications without checking their blood glucose level. Regarding diabetes prevention, Many participants were unaware that diabetes could be prevented. Some felt diabetes can be prevented by avoiding sweets completely. A few wished for a diabetes vaccine similar to COVID-19 vaccine. They asked us to convey it to you, sir, that we need to, they told me specifically tell to Dr. Mohan that he needs to invent diabetes vaccine. So I wanted to add it here. So some participants were willing to act as diabetes ambassadors to educate youth. Many expressed trust in researchers and field workers for promoting prevention in rural areas. Some of them said till that death, diabetes cannot be prevented even if God comes. Those who don't eat too many sweets will not get diabetes. So later after the FGD, I tried to educate them of these misbeliefs. So overall, the diabetes management in rural settings could be shaped by addressing the knowledge gaps, emotional distress, cultural beliefs, economic challenges, emphasizing the need for tailored, culturally appropriate education and support intervention in these rural communities. So, thus summarizing overall key findings, there is an increase in the diabetes around 158.5% over the 11 years, and sharp decrease in pre-diabetes indicate a rapid conversion phase. And rural India is undergoing a nutrition transition phase with increased fat and increased protein intake with decreased carbohydrate intake. And physical inactivity is rising, especially among younger adults. Low community awareness were addressed using effective trust building strategies. Misconception, myths, low awareness, irregular follow-up, poor self-management, stress and family burden, gendered responsibilities were some of the reasons for the low diabetes management in the rural population. So, the quantitative findings informed us the problems in the rural community, and the qualitative findings informed us the cause or reasons for those problems, and integrating that we can have a final solution of strengthening community-based screening, capacity building and education is very important for reducing the undiagnosed diabetes in rural areas. So, the future implications. This study provides a basis for future research on the effectiveness of various intervention strategies and the development of policies aimed at mitigating the growing burden of diabetes in rural areas. And the insights gained can inform public health strategies, program implementation, and policies to better address the evolving diabetes epidemic. These were the field activities conducted in the trend study using the telemedicine van. And few snaps on FGDs. The publication as part of the thesis include the objective 1, secular trend in prevalence of diabetes and pre-diabetes among rural population of South India, got published in International Journal of Diabetes in Developing Countries in the year 2023. And the qualitative study on perception and practices of diabetes prevention and management in rural South India got published in Journal of Diabetology in the year 2023. Challenges and the lessons learned in the recruitment of rural residents for diabetes screening program got published in International Journal of Diabetes in Developing Countries. These were the other publication which was not part of the thesis, but it was published during my PhD tenure. I have attended trainings. I'm a visiting graduate student in the Harvard T.H. Chan School of Public Health, Department of Environmental Health, Boston. And I also attended training on biostatistics and molecular epidemiology at Nanyang Technological University, Singapore, communicating research training in University of Kelnia, Sri Lanka, and advanced methods in qualitative research conducted by Samarth Institute in the year 2019. So, This PhD is a collective achievement, and I remain deeply grateful to everyone who supported me through this journey. My sincere and grateful thanks to our chairman, Dr. V. Mohan, our vice chairman, Dr. Ranjit Unikrishnan, and our president, Dr. R.M. Anjana, for this great support. Actually, I have prepared the script, but I couldn't able to express it now. Thank you so much for all your able guidance and continued support, sir and ma'am. And my thanks are due to my supervisor, Dr. R. Guha Pradeepa. Without her guidance, I would have not been completed this PhD. She is a symbol of peace, and there are no words to explain how calm and patient she is. So she is a very inspirational leader for me. I would like to share my sincere thanks to my doctoral committee, Dr. Nora Veghasani from WCC College, and my thanks in no particular order. I would like to thank everyone, the Trend Study team led by Dr. Rakesh in the Chunampet Center, and all the MDRF HODs and scientists for helping me to for a continuous support. And all my fellow colleagues who have supported for the statistical guidance. And all my fellow colleagues who have helped me in the administration and project support. My friends and colleagues. And my beloved family. I would like to dedicate this work to my late father. And also, I'm very thankful to my family as well. Thank you so much.
Yeah. Thank you. It was a nice presentation. Usually, whenever I come here, I look for some mistakes in the slides. This time, I'm disappointed.
Oh, thank you, sir.
Yeah, you made use of the technology very well, and the animated presentations were very good. Probably you use Prezi. You use Prezi?
Sir, he is the person who did the presentation, sir. I did give the content.
He can answer the question.
Which one you used?
I use multiple software.
Okay, good. So you know how to use the fonts and all that. I see that. It's very nice. I have some simple questions. Your title says secular trends.
Yes, sir.
So how many trends are there? Are there non-secular trends? Is it one of the trends? I'm asking you a very naive question. But
So,
what is secular trend?
secular trends is seeing the temporal trends or changes in the trends over the period, sir, for a particular disease outcomes. So, for me, in my thesis, I have seen the trends of changes in the diabetes prevalence and pre-diabetes changes.
Only one point, right?
Yes.
That's what sir is asking. Not multiple points.
Yes, ma'am.
Baseline and then one follow.
One for.
Yes, sir. Only the baseline as compared with it was conducted in the year 2010, and I have used another study which was conducted in 2021 to compare the temporal secular trends.
Of course, the textbook definition says it's a long-term process, like concerning the food habits and many other parameters, right? My question was whether there are any classifications on the trends, like secular trend, non-secular trend, and I don't know, maybe other types. Do we have anything?
So, I am not sure about that, sir, but why we have chosen that? This study was conducted in the same population, in the same study area. So, they are reflecting the same cultural practices. So, we thought of like they are reflecting the same area, because the Chunampet rural diabetes prevention project also conducted in around 42 villages of Chayur Taluk, Chittamur block, and this trend study also conducted in 30 villages of Chayur Taluk, Chittamur block. So kindly we can see the changes over this period in the rural population. So that's why we have kept the name as secular trends.
That's fine. See, the thing is, when you do research like on the experimental side, computational side and all that, it will be of interest to a particular set of people. But when you do epidemiological studies, it is of interest to everybody. Doesn't matter what is his background also. So that becomes more relevant. For example, when you said Chittamur district, all those things, I belong to some such areas. You have put it Kanjipuram Chandrapur district. I belong to that because sometimes we are called Kanjipuram district, sometimes we are called
Chengalpattu district.
Yeah.
Only Kanchipuram now changed to Chengalpattu.
Yeah, I know. That's why I'm saying I belong to both the districts.
Keep changing.
Yeah. In that one, however, I found some mistakes. That is, in the slide, the Madrandaram spelling was written wrong.
You're not disappointed.
You found
You're not
once.
disappointed. You found them.
Sorry, sir.
Tirupalkundaram was written wrongly. I found that, but I didn't prefer to say because you started that.
I told the sir, sir will look for faults. The grammar should be correct. Who was, no, where. Everything should be correct. So that's what she has done.
I think Dr. Mohan spilled that in an earlier viva. It doesn't matter. The secret of that is because I do not know the subject, probably I look at the sound. Doesn't matter. So the questions raised by some foreign examiner, they have asked, I think a Russian scientist has made this question, asked this question. Please describe how the EpiNew software version 2 was used. It's written that EpiNew software contains more than 1,500 recipes, and the Q study was used. The meal-based food frequency questionnaire with 22 items. For all these items, among the 1,500 recipes is the question he asked. So, what is your?
Sir, the EpiNew is the in-house software which is used to compute the daily energy and nutrient intake. So, in the CURE study, around 222 items was used for computing the nutrient intake, and in the trend study, around 180 items we have used. So, this software has 3 components of consisting of a master food data collected from various outlets. It has a nutrient composition of ultra foods and ultra processed foods and few 1,500 recipes, and also the raw composition of the food ingredients which was retrieved from the nutritive value of Indian foods record as well. So all these will be mapped into the nutrient software, and once we enter the participants' food intake, so it will each food will get mapped to approximately to the closer food, and then due to the log calculation, this software will give you the entire macronutrient intakes of the study population. So that's how the EpiNew software is used.
There were 2 versions, sir. The first version 1, which was done for cures. Then after the ICMR NI guidelines came up, then they've included one that has become to 180 food items. So that is the version 2 where it has been updated.
The other question is, the candidate has identified few barriers in rural diabetes screening and management. What would you advise to improve the situation? That is the question.
So, strengthening the rural healthcare system and also community engagement, it is very important, sir, because we do have a rural stakeholders there, and also there also needs to be some participation from the community as well. So, improving and strengthening the rural healthcare infrastructure and as well as some new intervention programs to make the participants to engage, this could help to improve the current situation better.
The secular trend actually talks about the transformative change, right, over a period of time. So, what do you think was the transformative change? Of course, it was a very nice presentation. Congratulations.
Thank you, ma'am. So,
What is the best driver?
yes, so right from the beginning, when we compare even the clinical and general characteristics of these population, we could see a good improvement in the formal education, which is very nice. But then the formal education also was the predictor for diabetes in this population, and there is a shift from the agricultural occupation, and many shifted to non-agricultural kind of a clerical and sales other work, increasing their sedentary activity and even the physical inactivity as well. So we often think or we perceive that people in the rural population are very active. Now then, if we see the numbers, it's just disappointing that the sedentarism is also increasing over there. So these could be the drivers for this increasing burden in the rural community, which is always unanswered and remains limited. So that's the focus of this research work, to get the world that even the rural India are facing all these kind of diabetes burden, and this needs to be addressed very urgently. So that's my
Something to do with the literacy, like it might have increased.
Yeah.
They showed that. She showed that.
Education.
Yeah.
It is yes.
yes.
Can I?
Yeah, please.
Fantastic presentation, Lakshmi.
Thank you, sir.
Excellent slides. I think you got help for that, but you utilized it very good. And even I was able to not pick up. I'm not able to pick up too many errors. I was also looking for errors, but I couldn't find. So that way, it's a fantastic presentation. So also, as Dr. Karunagaran said, it's a very useful piece of work because it tells us exactly what is happening. You mentioned the epidemiological transition very well and brought out the point that while diabetes has increased, pre-diabetes has decreased, which means fast conversion has occurred. Within 10 years, so much of the pre-diabetes has converted to diabetes. Now, regarding the question which rather asked what is the main driver, in the INDIAP study and in other studies, we are actually saying that carbohydrates should go down and protein should increase. And both have happened here. And despite that, the prevalence rates have gone up. Could be due to several things. One is, while the carbohydrate might have gone down, the quality of the carbohydrate might have made a big difference. It could have been little bit more whole grain taken at that time, and over a 10-year period now should have complete white rice intake.
We have seen the low millet and whole cereal intake in the study as well.
Then the rice itself, the quality of the rice could have changed. So while the quantity of the carbs maybe have gone down slightly, the quality may have worsened very much. Number one. Number two, I think your study and other studies here have brought out the role of fat. So fat has increased, and it's saturated fat, not the monounsaturated fat, protective fat, which is going up. Omega-3 is not going up. The omega-6, which is bad, and the saturated fat. So that could be another driver. Most important one is probably physical activity. Physical activity has gone down so much that even that little decrease in the carbs is, as you said, you saw clearly that the agricultural activity there has gone down. And this is what Abdul Kalam, when he came last to Chunampet, the same place when we met him there, he met all the farmers and he was talking to the farmers and he was saying, my fear is that, he had predicted this long ago, and he said, my fear is that all your sons and your daughters will not take up agriculture. So if they don't do that, who will produce the food for India? And India is surviving because of all of you. So please continue the farming that you are doing. But clearly, their farmers are looking for other jobs, and which is in the field they have been working more.
So the farm lands also, they are just selling the plots now there, sir. The farming land is also getting reduced. When we visit Chunampet, we often see that as well, plots for sale. So there is no land for
migrating that work. I think Pradeepa has done that work of migration and shown how that affects. Finally, I just wanted to say that Lakshmi has, through her contact with the villages now, she has developed such a deep understanding of that she has picked up new things which are very relevant and emerging there, like pollution, and recently the work on cooking fuels, biomass and the fuels, which is also adding to indoor pollution. And now she has, after her visit to Harvard now, has slightly switched her focus to newer areas which nobody is studying to my knowledge, environmental health, looking at pollution, and she has some publications coming out on that. So the stint that she had in the rural areas has helped her to understand rural Tamil Nadu particularly and what are the needs for that. And hopefully your future work, your postdoctoral work, will help to produce some solutions as well for the problem. So congratulations.
Sure, sir. Thank you so much.
Currently, two small projects are going on, sir, for monitoring, personal monitoring as well as outdoor monitoring. Apart from the ICMR project with sanction, the pilot ones are going on.
Yeah, added to that, I have also seen, like personally also, like I belong to that place I told you, So I saw that for my own lands, it's a personal experience. I tried to get some workers, nobody is coming. That is the reality.
Yes, Dr.
So Lakshmi, congratulations.
Thank
it
you.
was really fantastic, a learning experience I think for everyone sitting here as well. Lakshmi came in for the DClip project many years ago, and today she stands few minutes away from being called Dr. Lakshmi. Yeah, that has been a fantastic journey. Lakshmi, I've seen that happen over the years. Not just in science, but as a person, the transformation has happened to her as with everyone else. Now, with your thesis, I think some fantastic output has come from that, with huge public health, policy making kind of data has been generated. As Dad was talking, I was thinking about how I think importantly you have moved to the environment, because just the quality of carbohydrate being generated there itself could be, not as high nutritional quality as it would have been, say, 10 years ago, because of environmental pollutants. Dr. Balu was talking about endocrine disruptors. We don't know all of these things, whether they're actually having an effect. And so overall, I think that moving to that, we've made some really good points. The other thing about this, where we found that the diabetes prevalence is really linked with that carbohydrate decreasing and protein is in Northeast. But the difference there and what she showed is added sugar. There's no sugar intake there.
She
See,
showed
the fat and the sugar. So the fat and the sugar, the physical activity, 4 times higher. Fiber went up because fruit and vegetable intake went up. So fiber, good things happened. Fiber went, and the beautiful qualitative piece came in for understanding. I was really outstanding presentation.
Thank you so much, ma'am. Thank you.
Very nice presentation, Lakshmi.
Thank you, ma'am.
We enjoyed your presentation,
Thank you.
visually as well as the scientific part.
Yes.
Just one question. If you have to answer, based on the main results that you showed, the diabetes rates are increasing while pre-diabetes is coming down. So, what 2 things do you think are the drivers for this?
Usually in pre-diabetes, we do have a small window period where the pre-diabetes, from normal they'll get pre-diabetes and then pre-diabetes conversion to diabetes. Here there is a transition from the direct from the individuals are NGT or they'll get converted into diabetes directly. The shrinking window period for pre-diabetes is very lesser. So that is the drivers again. You asked about the drivers, no ma'am?
You showed everything, but if you want to list the 2 most important drivers based on your experience.
So the 2 most here is like when we showed here is basically physical inactivity in the rural population and also shift from the agricultural occupation and they have moved to non-agricultural work. So that is the major symbol of if you consider rural, then we can see agriculture is more, but now there is a shift and thus the reason for all these huge diabetes burden.
Once again, well done.
Thank you.
Yes, I think she has some
Oh, okay, please.
Wonderful presentation.
Thank you,
As
ma'am.
Dr. Angela said, I've seen you in that and you've grown up very nicely and your presentation is excellent.
Thank you,
I
ma'am.
have one question for you is that you have shown about this mixed method where you have shown on quantitative as well as qualitative. So I think there should be some limitations which made you go from a quantitative to qualitative analysis, and what did the high profile you got from the qualitative analysis? Did you find something interesting compared to the quantitative analysis? And also to add on what Anjana said is about the physical activity, I'm very close to mental health. In future study, if at all you take something on the stress and depression, could also enhance more research.
Sure, ma'am. So, regarding quantitative studies, see, if we go to rural India, initially, while we are doing the screening program, we did encountered lot of challenges, and then and there we also find out the strategies and how to overcome that. So all these were documented earlier. So now then what we try to do is, rather than telling simply, because this are our shared experiences and challenges could be helpful for some other researchers, those who are trying to do it in the screening or any kind of a problem, any kind of a research work in the rural areas. So thus I thought of like including a qualitative study. We also use the study staff as the study sample here. So they are also reflecting the cultural background from the rural community. And moreover, for diabetes management, when we see the numbers of increasing in the HbA1c or decrease, we could not know like what is the other side of the people thinks about it. When we asked them, they said like for diet we have to take rice and reduce the rice, increase chapati, something and all. But still at the back they are also saying who will prepare all these things? We can't afford, we can't eat. We need a lot of rice. So all these needs to be documented, because these perceptions also required for the future or clinicians to understand why they are not doing it. So that is the reason I have included qualitative component in this, to make the integrated or comprehensive approach. So that is why I have added. Thank you.
Okay, it's time to consolidate. I agree with everyone that it is a very good presentation. Congratulations to you.
Thank you, sir.
Can be called Dr. Lakshmi. We will formally send the papers to the university. So the one point that I want to make is that these kind of PhDs, you see people have a tendency to make statements without data. People will say, okay, nowadays diabetes is increasing, something very loosely. But you are providing data on that, and then you are making statements, which is good. The other thing is, as Dr. Anjana pointed out, your thesis also adds up another dimension, that it could help in policy formulations for the country, for the state, whatnot. So in that way, you can be proud of your work, and we all congratulate you again. Thank you.
Thank you all.
Congratulations, Dr. Lakshmi.
Thank you, ma'am.
I just want to say a few words regarding Lakshmi. She is actually dedicated and committed. So I first told only the quantitative will do. She said, no ma'am, you will get the perspective. That's why the qualitative thing came in. Said, will you be able to go? You need to go several times. Said, that's not a problem, ma'am. I will do. And she went for the separate training for that in 2019. And then she took up. So now all the FGDs which are coming, she is handling in my department. I'm really proud of her. Congratulations. Thank you.
Congratulations to guide also.
So thank you all in all. My heartfelt thanks for all of you for taking time, and our external examiner always welcome to MDRF. Thank you all. Thank you so much for joining.
We'll get a picture.
Yes.